The frontline treatment of myeloma for those patients who are newly diagnosed and who are not eligible for stem cell transplantation really is built on the backbone of two regimens, Velcade, Melphalan and Prednisolone, called VMP, and Lenalidomide and Dexamethasone, called RD for short. The seminal trials that laid the evidence for these regimens, of course, were published several years ago now, and what we've been doing in the last few years is really building on the evidence, refining our use of these regimens and optimizing their employment and their scheduling and dosage in order to maximize the benefit for patients. So for example, the VMP regimen has come a long way since the original VISTA protocol. Today we understand that using weekly dosing and the subcutaneous route makes this far more tolerable, reduces the rates of peripheral neuropathy and the rates of discontinuation. Patients are able to stay on treatment for longer and with greater benefit, as was shown recently in a publication by Mariví Mateos, which showed that the greater cumulative dose of Bortezomib received correlates with improved progression-free survival, although of course this was not a prospective randomized trial in that sense. As far as the Lenalidomide and Dexamethasone protocol is concerned, I think we've learned that whilst there is clearly a PFS benefit for continuous RD over RD 18, which is 18 cycles of RD, and certainly versus the third arm in the study, which is MPT, we understand that the benefit of continuous RD is probably most marked in patients who achieve a deep response. Patients who achieve a CR and VGPR have a time to next treatment of over 2 years, and this is very, very impressive. Perhaps it is more difficult to deliver in patients with impaired renal function, but this trial is remarkable for the inclusion of patients with a creatinine clearance of less than 30, so that we have at least a good understanding of how to deliver the regimen in patients with severely impaired renal function. There is of course the question of genetic risk, and perhaps it is true to say that for patients with adverse genetics, perhaps the RD regimen is not an optimal choice. This was supported by some evidence presented at ASH last year by Alessandra La Rocca. She looked at non-transplant eligible patients entered into Velcade-based treatment trial and a Lenalidomide-based treatment trial, and demonstrated that while the Velcade treatment regimens equally benefited both standard and high risk, the Lenalidomide treatment regimens actually preferentially benefited the standard risk patients.